Hi friends, I am Dr. B.V. Rao of Shah Clinic and founder of the websites qmedicaldoubts.blogspot.in and raghvamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the rickets. Diagnosis and treatment. A number of closely related compounds possess rickets preventing properties, some of them on exposure to the ultraviolet irradiation, that is sunlight, undergo structural anti-ractic. Only two activated sterols are important in nutrition and therapeutic. Ergocalciferol D3 and cholecalciferol D2 ergocalciferol and D3 cholecalciferol. Rickets is a disease of calcium and phosphorus metabolism, usually in infants and children obtaining insufficient vitamin D. The intake of calcium is low due to insufficient milk in diet or insufficient vitamin in mother's milk or animal milk, lack of exposure to sunlight. Chemical pathology. With the deficiency of calcium in the body below 2.5 milliequivalents per liter, which causes tetany, the serum phosphate falls from normal value of 4 milligrams per 100 ml in response to parathyroid due to low calcium. Clinical rickets may occur when calcium and phosphorus in serum are within normal limits. A diagnostic change is an increase in the serum alkaline phosphatage. Clinical features. The infant may appear well nourished but is restless, fretful and pale, with a flabby and toneless muscles. Excessive sweating of the head is common. The abdomen is distended due to flabby abdominal muscles, atony of intestines and fermentation in intestines due to excessive carbohydrates. Diarrhea is common, prone to respiratory infections. Development is delayed, causing late in eruption of teeth, sitting, standing and walking, etc. Bony changes are most characteristic. There is a widening of epiphysis at growing points where cartilage meets the bone. The earliest being craniotabs. It is diagnostic before 1 year of age. Enlargement of the epiphysis of lower end of radius and at costochondral junction. Rickety rosary of the ribs. Bossing of the frontal and parietal bones. Delayed closure of anterior frontanelle. Still later there may be deformity of chest such as prominent sternum, pesial chest. Harrison's sulcus is common during a respiratory infection. In doses, if disease continues to 3 years, these signs may persist or magnified. Deformities like kyphosis may develop due to gravitational and muscular strains. There may be enlargement of the lower ends of femur, tibia and fibula. As the child starts walking, knock knees or bow legs are resulted. Kyphosis often replaced by lordosis. Pelvic deformities may follow when there is a reduction in level of ionized calcium. Infantile tetany may result with spasm of hands and feet and vocal cords, which causes high-pitched distressing cry, difficulty in breathing. Sometimes there may be convulsions. Diagnosis. A flabby baby at the end of the first year, unable to stand, less tooth, profuse sweats, may be suspected as rickets. A radiological examination of the wrist will show characteristic changes at the epiphysis. The outline of the joint is blurred and hazy, epiphyseal line broadened. Later, in older children, the classical concave saucer deformity is seen. Raised serum alkaline phosphatase may be diagnostic. Differentiated from infantile scurvy, congenital syphilis, achondroplasia and osteogenesis imperfecta. Radiological examination differentiates the diagnosis. Treatment. The two essentials of the treatment are the supplementing the vitamin D and intake of calcium. Vitamin D. Therapeutic doses of vitamin is 25 to 125 micrograms daily. Cod liver oil or halibut liver oil. For severe cases requiring more doses may be given calciferol. A single dose of 3.75 milligrams can be given by intramuscular injection. Calcium. The best source of calcium is milk. Tablets of calcium gluconate 600 milligrams, one tablet 3 times a day. For resistant cases, calcium gluconate effervescent tablets of 4.5 grams each 3 times a day. For emergency cases of tetany, calcium gluconate injection can be given by slow IV or IM at dose of 10 to 20 ml. It contains 1 gram of calcium gluconate in 10 ml. For infants, the dose may be 300 to 600 milligrams. General measures. Hygienic environment is created for the child. See, the child is exposed to sunlight as far as possible. Progress. Radiological evidence is the first and only change showing healing of growing ends of the bones. Vitamin D. Resistant rickets. Sometimes rickets is resistant to vitamin D, persists into late childhood, late rickets or adult life, producing the clinical appearance of osteomalacia. The reason may be Fanconi syndrome. Prognosis. It is not life-threatening, but untreated may be prone to infections. Skeletal changes in mild cases may heal spontaneously, but the changes like a Pigeon chest persist. With early treatment, these changes can be prevented. Prophylaxis. Adequate milk for children. Slums are modified. Sunlight and ventilation must be adequate. 10 micrograms of natural vitamin D is recommended as cod liver oil supplement should be treated from the age of 4 weeks of birth. That's all about the rickets diagnosis and treatment, and in the next video I will discuss about some other disease. Thank you.